Welcome everyone to the Underserved Population Network call with Home Health Quality Improvement National Campaign. I'm Misty Kevich and I'm one of the nursing coordinators, and so we welcome you for taking out time today to join us. Just as a reminder, the slides for today's presentation are posted on the Up Network tab, and I do have a link in the chat box that you can connect and download the slides. We do want you to submit your questions as you think about them. You can put them in the Q&A box, or you can send them to all in the chat, onto the chat. We'll make sure that we address those as we go along in the presentation, but I know for myself it's best to type it in when you're thinking about it, because as we progress through slides, sometimes I forget what I wanted to ask in an earlier slide. So if we could have the next slide, please. Thank you. I'm very pleased today to introduce Marian Essie as the Director of Clinical Community-Based Services for the University of Pittsburgh Medical Center in the Insurance Service Division. In this capacity, she has led multiple clinical interventions and initiatives, including community-based case management programs, home telehealth programs, and specialty case management programs for the dual-eligible population. Prior to her current position, Ms. Essie has served as the Vice President of Performance Improvement for Celtic Healthcare and as the Director of Healthcare Quality Improvement for the Home Health Quality Improvement Support Center and the Pennsylvania's Quality Improvement Organization, Quality Insights of Pennsylvania. She has served as a technical expert for Centers for Medicare and Medicaid Services Panel, as well as the Home Health Publicly Reported Measures Resource Finder, and is a member of the CMS Transformational Change Work Group. Ms. Essie holds a BSN from Indiana University of Pennsylvania and is pursuing her master's in organizational leadership. And I'm very pleased to turn it over to Ms. Marian Essie.
Thanks, Misty. Thank you all for having me today. As you can tell from my background is strongly home health. I am a diehard home health fan and believe in home health to the core. So you might be thinking, well, how in the world did you ever, get at an insurance company being such a home health diehard? And I was recruited here. They were starting to look at many more community-based initiatives from my health plan, and I ended up here. But I always have a flavor of home health with me, and as you'll see as I talk a little bit more about what we're doing here at my health plan and some of my thoughts on some of our underserved populations. So today what we're going to be doing is I'm going to help you all identify the most challenging underserved that are served by our managed care population or our managed care organizations. Take a look at what potentially the role for home health could be or other community-based organizations in partnering with managed care to help aid our underserved populations, and then look at potentially what some best practices could be. So first of all, talk a little bit about background information. I have to say probably one of the biggest challenges that I had when I was preparing for this presentation was I have so much background information to kind of build some context about what I'm going to be speaking to. So bear with me till I get to the meat of it. I think you'll find it's somewhat interesting. So first of all, I just wanted to tell you where I am today. For those of you that are in Pennsylvania, you probably know of UPMC. For those of you outside of Pennsylvania, you've probably heard of the University of Pittsburgh. So I am with the University of Pittsburgh Medical Center. Our corporate organization is just gigantic. And I always like to think of it in numbers of employees. So we have over 55,000 employees in my organization. I work inside the Insurance Services Division. We have about 3,000 employees inside my Insurance Services Division. But what you can see from here from the slide is that we have multiple very large organizations under the umbrella of UPMC, hospital and community services, physician services, insurance services, and we're also international. Just within my Insurance Services Division, we have multiple lines of business and multiple products and services that we offer. Again, just to put it into context, we are just gigantic. So what I would really like to talk about, first of all, is take a look at health plans and some of the departments within health plans and how they interface with home and community-based services, or really how they interface with any provider, to be quite honest. So what I have listed here for you is a list of what the potential departments are within a health plan. I'm telling you from my perspective what I see from my health plan. You're going to see similar things in other health plans. They might be called something different. It might, have some snazzy name, but they all have these types of services. The first is member services, and member services, their role predominantly is inbound and outbound calls. If you or I picked up our insurance card and called the number on the back of it, we would go to some type of a member services line. These are typically not clinicians that answer the line. They're highly trained in the benefits and the plan design that the members have. The next is utilization management, and I really, really think that everyone, when you think of health insurance, thinks of utilization management, and I know that every one of you probably thinks that of those 3,000 employees that we have here, that, 2,500 of them are utilization management. My utilization management director would love that, but that is not the case. Utilization management is by far not the largest department. They do authorization processing for the most part and get involved with appeals and denials and those types of things. They typically are clinical staff, typically are nurses, and they do have non-clinical support staff. Then there's the case management department. Case management is where I reside. It looks at care coordination for members, the clinical regulatory, the things that we must do by state requirements, if for managed care plans or federal requirements that have a clinical component to it. These could be nurses, social workers, non-clinical people, health coaches, certified diabetic educators. Some of them are licensed, some of them are not licensed. Just a whole wide variety of professionals that can support the health plan members. And you're going to hear me say different times today, I will say member, and that was one of the challenges that I had coming to a health plan is I'm so used to thinking patients and patient-centered. And at the health plan, the lingo is very different, and we talk about our members, the people who are members of our plan. So I might slip up and say members every now and then. The next department is health management, disease management. These are the health coaches. These are the staff that really do the coaching for lifestyle, people who want to lose weight, people who want to have stress management services, people who want to stop smoking, and they also do disease management. Again, different health plans have things structured differently, but you're going to find these types of services in all the health plans. And the next is the quality department. They're looking at the HEDIS measures. So what does it take to actually get through accreditation by an accreditation body? A lot of times that's the quality department. But the HEDIS department is certainly looking at closing those gaps in care, getting the A1C that is required for the diabetics, having the colorectal exams, all of those gaps in care that the members might have. So what I am going to talk to you about today is really the case management feature or function within a health plan. And I can tell you, again, from my perspective, I've been with UPMC Health Plan outside of the home health role for now 2.5 years. And I think one of my big takeaways when I came to the health plan was just how much there was behind the scenes that providers don't know exists, that members or patients don't know exists. And a lot of that falls within the case management and health management department because there's just a lot of functions that go on there. And I want to talk a little bit more about some of those functions. First of all, within then the case management department, here at my health plan, we have multiple different types of case managers. Not every health plan is going to have this, but I think it might help all of you to understand this a little bit better. First of all, there's a telephonic case management. These are the staff that sit in cubicles, or many of our staff work from home. They are on recorded lines. They do outbound calls to the members to help support them in care coordination needs or educational needs. They do a lot of care coordination between the physician office and the member or multiple physician offices, but they're telephonic. They don't ever see the members face-to-face. Next are practice-based case managers, and this is something that is becoming more popular with health plans and certainly more in the ACO world that we are moving into, are those case managers who are actually embedded within physician practices. Here in my health system, we have a very large patient-centered medical home. We have over 70 case managers that are in, I don't even know how many physician offices right now, but it's a huge patient-centered medical home. And they are known as practice-based. And their role is very different than the telephonic case manager. The practice-based case manager is actually meeting with the members when they come into the office, trying to get members to come into the office as needed, following up with the members after hospitalizations, again, to get them back into the physician office so that that physician can be the center. It can be a true patient-centered medical home where the patient's home is with that primary care physician, and our practice-based case managers support that. Next, we have mobile or community-based case managers. And the mobile community-based case managers are actually, a lot of times people think that they are home health. It's an extension of home health, or it's duplicative of home health. And that is absolutely not the case. At least in my health plan. Maybe in some there is some type of a provider type of role. In my health plan, that's not how it works. These are nurses and social workers who really are in the homes, under the bridges, wherever they need to be, in the homeless shelters, to find members that really are most in need, and really many of them have serious behavioral health issues, significant issues with either socioeconomic challenges that they have in their life. So these are people who really meet the member where they are, and truly that oftentimes could be in places that none of us hope to ever go. And then finally, we have facility-based case management. Facility-based is, again, it's becoming much more popular, I know, in some health plans. And these are the formal transition coordinators. These are case managers who, their typical role, of course, it could vary, but what I'm seeing, what we have here and what I'm hearing other health plans have, are those case managers that actually are in a hospital and help the members with their transitions of care. Some are following, the various models of care. Some are following Project Boost. Some are following Project Red. Some are following the Coleman model. And then aside from that, facility-based, we also have facility-based at some nursing facilities here, skilled nursing facilities. And again, a lot of times what they are doing is helping with transitions for people who are coming in and out of the skilled beds, but also helping to identify those high-risk members that really need turfed up to a higher level of care within the nursing home, maybe not to skilled, but maybe to just get to the attention of a nurse practitioner that might be on site to help service their needs and prevent a hospitalization. So here at UPMC Health Plan, what I do is I actually have two very large teams. I have a team of telephonic case managers, and I also have a team of the mobile community-based case managers. So as we speak today, I'm going to be referencing a little bit more about those teams and the things that they do. So let's jump in and take a little look at what are underserved populations. And I can tell you, from my perspective, again, coming from the home health world, and my background in home health, I have well over 20 years experience in home health in every capacity that there could be in home health. When I came to the health plan, I really expected to be taking care of members here that were very similar to the people I took care of in home health. Hey, my team was going to be going into the home. How different can it be? It's is pretty much all the same. And I have to say that I was really, really, really wrong. The underserved populations that we serve at the health plan, and I think most health plans would agree with what I'm saying, are oftentimes significantly much more challenging than what you're going to find in your typical home health agency. So I'm going to just jump in a little bit, give you a little background. Here, a little more contextual information. In health plan lingo, we always are talking about the lines of business. And, you know, one of the popular theories now in healthcare, anything, is segmentation or segmenting populations and identifying certain populations that have certain characteristics so that you can actually provide interventions or treatments that are better in alignment with whatever those characteristics are. So in health plan lingo, that segmentation typically follows by the line of business. And so not every health plan has every line of business that I have listed here, but the larger health plans will most likely have the majority of these. So the first line of business is commercial. And commercial is really typically probably what you all are. It's what I am. This is the insurance that working people have or that you can buy on your own. So it's very employee-based, self-pay. One of the biggest challenges here is health management, lifestyle coaching. So for this population, that when you think about what are the special needs, a lot of times, again, think of them like us. You know, we want to lose weight, we have too much stress in our lives, maybe our blood pressure is a little bit high, and we need to understand how to manage our blood pressure better. So that's typically what you're seeing in this commercial population. They really need a lot of education and support. Next is the CHIP population. This is the Children's Health Insurance Program. This is a program, a federal program that for families with too high of an income for Medicaid, but they aren't high enough to be self-insured. So they really, you know, this population is in a financial crunch. So their decision-making is really based upon, boy, I really want to put this money out so my kids have really good insurance, but I have to work really hard. And, you know, these are the numbers that you see that are going to the urgent care or to the emergency room late at night because mom and dad are working, and it's the only time they have to get their kids' health care sometimes. So next is Medicare. And from a home health perspective, I can say that the Medicare that we see here is pretty much like the Medicare that you all take care of. And I'm going to make the assumption that most of you are going to be predominantly a Medicare-based organization with getting other lines of business as well. These are typically the 65 or older. You know, they have oftentimes high health care utilization, and oftentimes they do have home health care. You know, the Medicare people we see, they typically do like going to their doctor. They believe in their doctor. They have a good relationship with the doctor. They tend to like or have a nice accumulation of medications from going to a lot of doctors, which can be very challenging. But again, I don't think that we see anything typically all that different in the Medicare people than what you see. Then we also have Medicaid. You know, the unemployed or the working poor have significant, oftentimes, lifestyle and socioeconomic issues, and these many, many times overshadow their health care needs. So, as you can imagine, when you're worried about where the next meal is coming from, it's a low priority to be worrying about, you know, getting to the doctor, getting prescriptions filled, those kind of things. And one of the things that definitely, and I know I'm preaching to the choir here because you all can tell me this just as well, is that they can be transient. I mean, I always say that they're slippery. They slip right out of your fingers. You're there visiting them one day, you're at their house, or they're on the phone, and you have plans to follow up the next day or 2 days later, and the phone's been disconnected, and there's no one at the home, and, you know, very hard to find them. So the Medicaid, from our perspective, and I'm thinking from yours also, can probably be a little slippery and sometimes just very, very transient. And finally, the special needs plans. These are the dual eligibles, the people who are eligible for both Medicare and Medicaid. Now, we know that not every person who's eligible for Medicare and Medicaid actually gets the special benefits of the special needs plan, but for those who do, We have a very large plan here, 17,000 members, probably one of the top 10 largest in the country, and this is one of the plans that I am responsible for from a case management and a clinical perspective. From this perspective, we really see the people who have the disabilities. I believe the average age of our members here about in their mid-50s. They have a lot of socioeconomic issues. Oftentimes have chronic illness, including that mental health or behavioral health issues. So what I would really like to hone in on, talking about the disparate populations that we're talking about today, looking at members who are typically the Medicaid and the special needs plan member. Now, what I'm going to be talking about today, you can certainly see in commercial or CHIP or Medicare. You can see them in any of those lines of business. But typically, they tend these needs and these identifiers are typically more often associated with Medicaid and the special needs plans. Okay. So I'd like to just spend a couple minutes here kind of thinking about, from a managed care perspective, what are all of our most challenging underserved populations from a Medicaid and a special needs plan perspective. And I have them outlined here for you. Serious mental illness, SMI. Again, that's a new term that, to me, coming from a home health environment, I was not used to talking about SMI, and SMI is part of my daily lingo these days, serious mental illness. Culture of poverty. I think we have all recognized and certainly all been in those homes that are meeting the poverty threshold, very common for home care. But from a managed care perspective, thinking about it as really a population, because there are such unique needs of the people who fall into this bucket of the culture of poverty population. Intellectual disabilities. This is another one that's really growing near and dear to my heart. We have some new programs that we've started here at the health plan for our members that have intellectual disabilities. So I'd like to talk a little bit about that. Behavioral health. Again, from my background in home health, certainly worked with behavioral health nurses or the psych nurses, as we oftentimes would call them, that can tell you that from a managed care perspective, looking at specifically our Medicaid and our special needs plan or our SNP population, that we deal on a daily basis with much more significant behavioral health issues than typically are the routine in home health. Palliative care. And I'm going to talk about palliative care from that little other perspective. I know in a home health setting, oftentimes when we think of palliative care, we think of it as a pre-hospice or palliative care as part of hospice. We're going to kind of talk about it just a little bit differently here. And then rare and chronic conditions, looking at those conditions that are not all that common in many instances, or they are chronic and can be terribly disabling and challenging to manage. So those are the 6 populations I would like to talk a little bit about this afternoon. So the first one is serious mental illness. And again, as I said to you before, this is a brand new term to me coming in from home health. One of the things that definitely was a learning curve for me in over many, many, many years of home health was very conditioned to using social workers in home health, but being very, very rigid in following the Medicare manual for home health and the payment regulations. So as the years progressed, I can't certainly speak to what was happening in your home health agencies, but I know in the places that I worked with that the social work visits were really drastically decreased. And I can tell you from a managed care perspective that we have a great, great need and a great respect for what social workers are bringing to the table, especially to these very challenging underserved populations. And so I think that's one of the gold nuggets I would really like to leave all of you with, is thinking about interdisciplinary teams and the role of social work in those interdisciplinary teams for these very, very challenging numbers that you have that probably do fall within some of these buckets, and maybe you just haven't recognized them as being in those buckets. As I look back, that's kind of what I think of. I think, gosh, I was looking at everybody through my home health eyes and not looking at them through that, the underserved eyes. And I think I probably would have been a better clinician and a better manager had I looked at them just from a different angle. So thinking about serious mental illness a little bit, NAMI, or the National Alliance on Mental Illness, gives a definition for serious mental illness. It can be major depression, schizophrenia, bipolar disease, obsessive compulsive disorder, panic disorder, post-traumatic stress disorder, or borderline personality disorder. And I will tell you that, all health plans talk about SMI. They have populations that they measure that have SMI, but the diagnoses that fall in this bucket might change. So I know for my organization, we don't follow strictly this NAMI definition, but just wanted to give that to you so that you can kind of ponder that as far as, who are the populations that you are serving that have this serious mental illness, and how well are they connected. When I think about what we have from a managed care perspective with our members with SMI, one of the biggest challenges we have are linkages. So in thinking about that, people that have these diagnoses certainly need linked with psychiatrists, need linked with behavioral health, community-based organizations. Many of them might also need linked with some drug and alcohol organizations, because oftentimes those go hand in hand. Clearly, these are people who all are on the path to chronic physical illness, as well as the mental illness or behavioral health illness that they have. So these are by far one of the most challenging patient populations we have, because when you really think about it, oftentimes these are the people that have the chronic physical health conditions, the chronic behavioral health conditions, oftentimes maybe do have then drug and alcohol issues, as well as socioeconomic and very poor support systems. So by far, the serious mental illness folks are our biggest challenge. I will tell you also that by far, these are the ones who, from a home care perspective, are going to most often get that label of they're noncompliant. But can you imagine someone with all of those things going on with them in their life being compliant? It's very challenging, these members, engaging them and linking them with the providers. I think that linkage with their providers and staying engaged with them as a home health provider while they are linked and stay linked with their providers is probably one of the biggest challenges. But these by far are where we need to go, or what we see as a valuable partnership from our home health agencies. The next population is that of the intellectual disabilities. And don't you just love this picture? I just love this little fellow here playing in the grass. When we talk about intellectual disabilities, for years now we've had the Diagnostic and Statistical Manual 4, and just recently that was updated to the DSM-5. And with that, they took out the references to mental retardation. This is what used to be known as mental retardation, and now it's the intellectual disabilities, which, my goodness, isn't that a much better term than mental retardation? So what we see with these numbers is that there are a lot of challenges with them. Many of these members have tremendous support. They're in group homes or residences where they have a lot of support from county or state funded services. But I will tell you where we really see the issues with these members and have a real need for partnership with home health, because I know home health gets these referrals. And that is when the members actually are transitioning between settings. So when the members or the patients are in a hospital and that discharge planning and going home and making plans and making sure that the equipment is right and the equipment is ordered and that the caretakers understand what needs to happen and that the folks in the hospital understand when they go in the hospital what's really happening with these patients. We have a huge, huge, huge challenge with these patients when they transition between the hospital and the home. It seems like nowhere in the system is there enough time or enough effort to really hang on to them to just make sure that those transitions happen as well as they possibly can. The next population is that of palliative care. And, I, for years, have followed an organization known as the Center to Advance Palliative Care, or CAPC. And their definition of palliative care, for myself, I have years of home care hospice bridge program experience. But I really like their definition of palliative care the best. And what they say palliative care is that specialized model of care, medical care for people with serious illness, focused on providing patients with relief from symptoms, pain, and stress of a serious illness, whatever the diagnosis. So they don't use the term end of life because these are not necessarily people that are end of life. These are people that have a serious illness and really need support or palliative treatment. The goal is to improve quality of life for the patient and the family. And this isn't always hospice or pre-hospice, as I've said before. It's really that focus on really helping to assure that that patient has the long-term, not just 30, 60, 90 days worth of support, but a long-term support for the management of their condition, their symptoms, connected with their health care providers. The challenge that we have, and I'm sure you can well imagine this, the majority of our case managers are oftentimes the telephonic case managers. So the challenge is really that conversation. Those people that really are being very aggressively treated and maybe do have a lot of pain and suffering and really are very unhappy, and just opening up that conversation. One of the things that is a positive with working for such a large organization that has multiple arms is I get to work with a lot of really neat people who are just way smarter than I will ever be. And I work with a well-known psychiatrist, and I think I think of some of the words of wisdom that he has given. And one of the things that he said that he always has done is that when he meets a patient for the first time, whether it's in the hospital, whether it's in the office, he always starts the conversation with, tell me about your average day. Tell me about when you get up in the morning. Tell me what you eat. Tell me what you like. Tell me what you don't like. Tell me what you do. And he said, I just listen to them. He said, I just listen to them. And he said, and then I asked them, what about that would you like to change? Or what about that can I help you with? And I thought, that's a simple, he said, I just listen. He said, I just listen to them. And I thought, wow, those are just such great words of wisdom. And I think of that with this population. Certainly that applies to every population. But with this population in particular, when you start asking those kinds of questions and ask really what do they want. So again, as you can imagine, it's challenging creating a relationship with someone on the phone. And then it's even more challenging having those difficult type of conversations. So, again, we place extreme value on our home health providers that are in the homes, that are face-to-face, and having those difficult conversations and helping patients try to figure out what they want and what they need is extremely important to us. So the next is the culture of poverty. And I can tell you that we don't have a pool of patients here that we call the culture of poverty people. We don't. That probably would not be very sensitive. But in training staff that are new to, especially those that are going out in the field to meet with members, you have to identify that there are significant issues that patients have that live with a culture of poverty. This term, culture of poverty, was actually coined by an anthropologist, Arthur Lewis, and it's defined it as the theory that helps explain why poverty exists despite anti-poverty programs. So it's like why we have all kinds of programs, tons of programs. I'm involved or in tune with many programs in my area that are truly aimed at reducing poverty and helping people with poverty, but yet poverty exists. And what Dr. Lewis went on to say is that the poor are not simply lacking resources, but they have a poverty-perpetuating value system. And the people in the culture of poverty have a strong feeling that they are helpless and don't belong. So I think, from our perspective of a health plan, it's very important for our staff to recognize this, that dealing with these people that have a lifelong, many generations of poverty is not going to be the same as dealing with the generations that we deal with. It's not going to be the same as dealing with the other populations. And again, I know I'm preaching to the choir. You all know this. But it's just very important for us from a staff perspective to recognize that, that these are people that someone told me recently, one of my staff that was out in the field, we go to people's homes, and again, these are not the nicer homes typically. They can be, but for the most part, they're not. And she made a comment to me that I thought was really, really interesting because, my staff, they all have business cards. And she said, I go to the home, and you'd be surprised how many people will answer a door without a phone call, not knowing anybody, but they do, the patients do. And she said, I talk to them about, what I could do to help them, and I have my business card. And she said, and they pull out a handful of other cards of people who want to help them. And I thought, wow, that's really interesting. I really didn't realize how many people actually are out there at that home level. But she said, we make the difference because we engage with them, we meet them where they are, and we stick with them to the bitter end. And I thought, great words of advice. These are people that time and time again programs have let them down, have made them promises and not fallen through, have shown up at their home for a while and then have gone away. So, I think that, from our perspective, from a managed care population and looking at this managed care program, looking at this population, the challenge we have is engagement because these are not necessarily people that want to engage with us. They don't necessarily see the value of it. They've been let down so many times throughout their life and throughout many generations of their family. So our challenge with these numbers is really self-management. So you're talking about people who have issues with high blood pressure, who have issues with heart failure, who have issues with diabetes, and have lifestyles that do not lend themselves to improving that. But how do we get them to self-manage? And from our perspective, it's the engagement, and it really takes a lot of work. Very tenaciously are we stuck with these numbers. So just some thought. I think that, from our perspective, that's a key training area for staff. Next is behavioral health. So, again, coming to a health plan, coming from home health, where for the most part the behavioral health issues that we really saw were, from my perspective, they were people who were, probably the older adults, more the Medicare people oftentimes that were maybe alcoholics, had been alcoholics, recovering alcoholics, have depression. You see depression very often, anxiety disorders very often. But I can tell you in a managed care environment, we are seeing behavioral health problems that are incredibly challenging and trying to help people get the help that they need. And, as you can well imagine, these are not always people who want the help. So, when you think behavioral health, it's kind of an umbrella term for mental health and substance use disorders. And thinking about that from anything from anxiety disorders, or maybe people who have some phobias. Not uncommon for us to run across those people who are hoarders. I know that you all know that. We have our own stories that we can tell about the hoarders. But again, these are the people that have any of those number of disorders that are causing them to have significant issues in either achieving a healthy lifestyle or achieving a good relationship with their primary care provider or sustaining that. So one of the big initiatives that we have here at the health plan that I'm very involved with is really looking at what can we do to integrate our physical health and behavioral health needs, because as we delve more into what really happens to our members who have behavioral health problems, the care that they receive is very, very siloed. If someone has a drug and alcohol problem, they're seen oftentimes by a community-based drug and alcohol provider. If they have a mental health problem, they're often seen by a psychiatrist and or mostly by a community-based mental health provider that oftentimes is not the same provider that they have for substance abuse. And then these are people who oftentimes are the smokers, are overweight, have chronic conditions. So therefore, they have a team of other physical health providers that they are also seeing. So the challenge that we have is linking everybody up, because as you can well imagine, these are not people who can do that on their own. I mean, as a wife of a person who has some health conditions, I often think to myself, I'm a very seasoned healthcare professional, and sometimes I'm challenged helping my husband navigate the system. So you can only imagine if you really needed all these various providers that all were kind of only looking at you from their little viewpoint, from their angle, how challenging that would be. And that's a huge challenge for us, is how do you actually link up all of these providers to make sure that everyone is in tune and understands what's going on. And of course, with this, you also have the consent issues, because these are people that have to consent to sharing information. It's not something that you can freely just pass out to anybody. So, I want to just pass along a resource. I would highly, highly encourage home health agencies that have not gone down this path of strengthening what they're doing with behavioral health to really, really look into this, because that is a huge need from a managed care perspective. There is a great resource on the SAMHSA website. I don't know if you're familiar with SAMHSA. It's a government organization, Substance Abuse and Mental Health Services Administration. They have partnered with HRSA, the Health Resources and Services Administration. In the government you have to have an acronym for everything, so they have two here. It's the SAMHSA, HRSA, Center for Integrated Health Solutions. And great, great, great resources on this website for training staff, for having programs. I would highly encourage you to take a look at this and really think, if it's not an avenue that you've gone down with your organization, strongly consider it, because the needs are just tremendous. Okay. And then finally, the rare and chronic conditions. These are the MS, the multiple sclerosis, ALS, inflammatory bowel. We even, consider rheumatoid arthritis, seizure disorders, sickle cell, hemophilia. I mean, I'm sure every managed care organization has some different diagnoses related to what they consider rare and chronic. But as you can imagine, from an organization that is responsible for managing and paying for people's health care, these are probably some of the most expensive members and the most challenging. Medication management is a big challenge with these numbers, because what will happen is that oftentimes, as you know, we all watch commercials, and the commercials from the drug companies these days are very much consumer-based. They want you to be attracted to all the things they have to offer. So if you have, inflammatory bowel disease, if you have rheumatoid arthritis, you can't watch TV from 8 to 10 at night and not find a cure there. So what happens is we have a lot of people who are ordered very expensive medications that that they aren't necessarily always compliant with, because oftentimes, as you can imagine, these are medications that cause some challenging side effects. So actually having people comply with the medications long enough for them to get over the side effects and to be well managed by their specialists or their PCP who's managing the care. And clearly these are people who really would benefit from from specialist management. But having that not just that from a home health perspective, you're in the home to see, yes, they're on these specialty drugs. I don't want to name any now, but again, you can think of any that you see in the evening, except for those ones where you have to sit in the bathtub holding hands. And think about my members or my patients are on these. Are they really taking them? Are they taking them as ordered? If they're taking them as ordered, what are the side effects they're having? If they're not, just because they have them in the bottle, are they really following what they're supposed to be? It's a real challenge. You'd be surprised how many of these people do not follow the medication management regime or follow it long enough to get past that period where their side effects can be well managed. So how can we kind of collaborate? Well, first of all, we have two separate viewpoints, and I think that the organizations need to take a little different view from the perspective of the other. From a home health perspective, at least from my past, I was so schooled in the, what is following the Medicare guidance for reimbursement. And, is it skilled care and reasonable and necessary care? Is the person homebound? Does it fall within that observation and assessment period? So really looking at what falls within the regulatory payment guidelines. Are they compliant with what they're doing? From a managed care perspective, and again, looking at case management, I'm not going to be speaking from the utilization management perspective, but from a case management perspective, we're looking at things like, are they engaged? Are they engaged with the providers? Are they home for their visits? Are they following up and making those appointments and keeping them with their PCP when they get out of the hospital? Do they have unplanned care? And if so, that was another new term, unplanned care. The people who go to the emergency room are hospitalized and it's not planned. That's something that we're always looking to try to reduce here. What are the behavioral factors and socioeconomic factors that are really influencing what's happening? I can tell you from a managed care perspective, because we can do population management, we do hold on to the members for a long period of time. We tend to look at what are their overall needs, not necessarily what are their needs for this episode of illness. And it's a different vantage point. I know home health can't always do that because of regulatory requirements, but having that vantage point of, boy, what really are the overall long-term needs is very helpful. Another thing we look at are really who are the high utilizers. Who are the people who go in and out and in and out and in and out, and who see, I was looking at a case the other day, and the poor fellow, he wasn't in and out of the hospital that much, but God love him, he loved the emergency room for whatever reason. He was there over 60 times. He was to see over 60, had 60 visits to his specialist, and he saw his PCP over 40 times, and that was just within a 6-month period. So, that would kind of fall within what we would consider the high utilizers, and those are the people that we really try hard to figure out what's going on. They're really challenging. But from a managed care perspective, we want to get a hold of them, engage with them, and really help them solve their health care problems. So what are some of the best practices? Well, I think, as I think about this, and I tell my boss all the time, I'm probably sound like a broken record because I'm so pro-home health and so partnering with home health. We're very, very fortunate here because part of our organization is a very large home health organization that very much wants to work with us and work very well with us. But as you can imagine, we have many, many, many home health agencies that we work with, and with a variety of skills. The one thing I can say that is most helpful is the communication, the conversation. And you probably are thinking to yourself, well, I just faxed my authorizations in. I don't really get to talk to anybody. How could I ever talk to anybody? That just seems crazy to me. And so I want to go back to thinking about one of the earlier slides where I was actually talking about the different departments. And So the one thing that you can always do is if you are working with a patient that is part of a managed care organization, that is a member of a managed care organization, and you really are challenged with this member and want to help and coordinate with that case manager at the health plan, you can always call that number on the member's card to get to that member services department to ask to speak with a case manager about the case. I would be surprised if you did not get a very welcome call back. Oftentimes, we are the ones that are initiating those phone calls, and sometimes it's very challenging to figure out, especially, where the member is, who's the provider, what's happening, and you think, well, that doesn't make sense. You're paying for it. But as you're well aware, everything that we see is only through a claim, and if a claim hasn't been filed, then we don't see it. So oftentimes that's very challenging. So communication, I will tell you, between home health and managed care is the number one best practice. And oftentimes that communication really does need to start with home health. From a managed care perspective, we welcome it. We would embrace that. Again, that's not looking at the utilization management department. They have a whole different role. They are looking at other things. Do utilization management and case management departments talk? Yes, we do. Yes, we do. And we talk when things bubble to the surface that really needs the attention of one or the other. So keep that in your back pocket. I think that's probably one of the best practices that you can have. This last slide, and I know Misty's going to be cutting me off here because I haven't left a whole lot of time for questions, but our case management interventions, just a list of the most common case management interventions that we have when we are with the members. And as you can see, these are not like being a home health agency. These are not being a provider of any type. These are very much case management. And if I were to pick the most important of these out of here, I would certainly pick, number one would be a tie between linking to the PCP and the medication review and reconciliation. I can tell you that oftentimes when my team goes into the home and does the medication reconciliation, we uncover huge messes, just as home care does. But those are two of the biggest. Linking to the PCP is huge. Oftentimes these are members, these really challenging ones, they don't have follow-up. They don't get to their PCP or the specialist if they've been in the hospital in a timely fashion. And we really like to get them to that doctor within 5 days of hospitalization. As you can imagine, that's very challenging. So anything home health can do to help encourage or promote that and help encourage and provide communication between the providers, because that is where we would be duplicating. That would be a huge help to manage care. And I think that my last favorite one here is really the advanced illness planning. There's just not enough of that goes on. I think even from me with my team at times, I think we're so quick to pull out the advanced directives or pull out the pulse, or we have something here that is a tool known as the 5 wishes. We're so quick to do that, and sometimes we do that without having that very challenging and lengthy conversation where you really just sit and listen and try and figure out what's going on first. And so sometimes the advanced directive planning just doesn't go as well as it possibly could. So with that, I'm going to wrap it up. Misty?
Thank you, Marianne. I think there was a lot of great insight through the presentation today from Marianne that we can all take in our environments that we work with our patients. And I'm going to kind of reiterate her top 2 picks, MedRec and linking to the PCP. I just got back last night from the IHI conference, and it was with physician practices and community services. And there are so many great opportunities. And physician offices are trying to manage their patients better. And, what a great fit with home health in learning how to coordinate and setting up and working together that they can, while working about patient outcomes. If there are any questions, please throw them in. I know we're close to the end of the hour. We don't currently have any questions, so do submit those either in the Q&A or chat. And Marian, we're just going to go ahead and do our couple announcements while we wait to see if there are any additional questions or any questions. So if you would turn the next slide, please.
There you go.
Great. We do have some HHQI resources that tie into some topics, and actually several that Marian talked about that. I was like, oh, I should have included this. But in our underserved population best practice package, I've listed the page numbers of different components of what she was covering today. Next slide. We also have Underserved Network calls that are archived. Here is one, and I'm going to tell you about another one that I thought of during the presentation. But this is a coordinating Medicare and Medicaid, and I guess my first comment is, with the presentation today from Marian, I think it gives us really great insight from the other side and putting quotes around the other side. But isn't it interesting from all perspectives? It's not all about the money and authorizations and confining the visits. We all are working on improving patient outcomes and improving quality of life. And we have to think out of the box. And Robin Wagner and Allison Bourgeon did a call back last March, and it was really talking about those type of things. The other one that is not listed on this slide, you may want to jot down, found in the same location, so you can use the link on the archive site, is compulsive hoarding for care managers. It was done 6/12 of last year, and it is a 2-hour session. The CEUs for the social workers no longer exist. It's out; those are expired. But the content was excellent on understanding compulsive hoarding. Next slide. We do want to invite you to the next up call, which is March 25th. It's Making the Most of Telehealth to Care for the Underserved Population by Alexis Silver. I think you'll be very pleased on that. You can click and go ahead and register for that under the Up tab as well. We'll go ahead and next slide. You can connect with us in many different fashions. We have lots of good information being provided in all of those locations. One other webinar I do want to draw your attention to is an archived webinar from a couple weeks ago, last month I guess, Evidence-Based Health Coaching. And it is listed under webinars. Melinda Huffman, excellent presentation, and it really does tie back into the care and this population that Marian has really talked about, and learning how to engage into making sure patients don't fall through loops. And next slide. Okay, we do have one upcoming, brand new, just announced for actually just last week, Mitigating Cardiovascular Healthcare Disparities webinar. It is now, you can sign up for it. It is March the 20th from 2 to 3 p.m. Eastern. Patrice Nickens, I'm not going to try to mess up the rest of her name. She is the medical officer at Heart Failure and Arrhythmias National Heart, Lung, and Blood Institute. It is open. She's going to talk about the new cardiovascular health disparities related to the cholesterol management new guidelines. So you can register. That's brand new. Go ahead and next slide. And that's our thank you. We're not seeing any questions. I think, Marian, it was just a phenomenal amount of insight and information, things that we see, that looking at it even a bigger level, great opportunity for collaboration. Any last second comments you may have?
No, just thank you for having me. I probably could have talked all day, so thank you for having me. I really enjoyed this.
Thank you very much for everyone attending, and we hope to see you again in the beginning of in 2 weeks. Thank you.